So, are the organisms important? Well, of course. How do organisms impact clinical decision making? And this is quite complex. You've already heard the discussions this morning, so I'm not going to be able to sort of overdo this, but I'll touch on it. And is the antibiotic regimen important? Okay, so this is obviously not specific to prosthetic joint infection. This is chronic osteomyelitis from the Oxford group. It's slightly old now, but it shows what almost all studies in terms of the microbial epidemiology of orthopedic infections show, which is that it's predominantly a gram-positive infection, about 75%. Doesn't matter what you're dealing with, 75%. There are one or two exceptions, like war wounded from Afghanistan, then it's very gram-negative and very resistant. But actually, outside of the very specific exceptions, it's always gram-positive. With about 1 in 5, 1 in 6 infections being gram-negative, which you need to be aware of and keep your eyes open for. The difference is when there's metal wear versus no metal wear in orthopedic infection in general. And when there's metal, then you get a higher proportion of the gram-positives being what I'll call low-grade pathogens, coagulase-negative staphylococci, or QT bacteria, what we call propionic bacteria previously. So metal is more associated with those organisms, but you do get low-grade pathogens, as I've already mentioned, sometimes causing early prosthetic joint infections and what look like acute, depends how you use those terms, but acute prosthetic joint infections as well. But I think overall, what I would say is one shouldn't get over-prescribed. I've become much less dogmatic about antibiotics as my career has progressed, and that's because the evidence generally is crap. And people will say you should do this or you should do that, but usually it's on the basis of some really poor study of about 100 patients and or some systematic review that might happen to have 3,000 patients, but it's 3,000 patients made up of completely crap studies. And a systematic review of 3,000 patients made up of crap studies is a crap systematic review. That's all it is. So we have lots of unknowns here. The last systematic review on chronic osteomyelitis didn't suggest any particular antibiotic regimen. And we're talking about systemic antibiotics now as opposed to local, and that's a whole different talk really. But there's no real evidence that any particular antibiotic regimen is better than others. I'm going to talk a little bit about rifampicin later on because there are some real sort of, rifampicin files, if you like, and I'm not a rifampicin believer. And I know that is like, oh, God, die on the spot, but I'm just not, I'm sorry. I've been doing it for a long time and I don't think it adds a lot and it certainly complicates management. But I'm going to do this through case, or partly through a case anyway. I don't think it's a case we managed particularly well in hindsight. It was quite a while ago. I think we've got better over the years. And partly, sometimes how you manage these things is based on what resources are available to you as well. But this was one of these patients that pitched up on the ward. I didn't know about them. They weren't discussed in the MDT because we didn't have an MDT then, blah, blah, blah. So I think it shows the importance of the MDT, as we've heard multiple times already. But this patient had previously had bilateral hip replacements in Africa in 2011. And we've heard this already this morning. The left hip required a washout, whatever that means, after the primary operation. But the patient had ongoing pain such that they were unable to walk. The wound was healthy and they'd moved to the UK and they ended up having a 2-stage revision. And they underwent the first stage revision. No preoperative microbiology was sent. I think now we would absolutely do an aspirate for obvious reasons. A gentamicin spacer was inserted and we wouldn't do that now because if you don't know the microbiology, you definitely don't want to insert only a gentamicin spacer. You definitely want a more broad spectrum spacer. But a gentamicin spacer it wouldn't have made any difference in this case actually. But a gentamicin spacer was inserted. And this is what we found in multiple tissue specimens, ESBL producing Enterobacter cloacae, very resistant. So only susceptible to amikacin, that's like gentamicin. People don't like using it because it causes nephrotoxicity, ototoxicity. Colistin, which is frankly a crap antibiotic, even though sometimes we have to use it. Ertapenem and meropenem, which obviously last line in, sort of in the defense antibiotics, if you like. Fosfomycin, so I think at the time we didn't have intravenous fosfomycin available in the UK. Now we do, we could have used it, but we couldn't at the time. There was very little data on temacillin at the time for bone and joint infections. Antigacycline, even the company tell you not to use it for bone and joint infections, although very occasionally we do. You can use it locally, but you can't systemically. It's not meant to be very good. The company actually says don't do it, but occasionally you do it when you're in a real corner. Now, sort of, this is where I got involved. So I think I got involved immediately post-op. I should have been involved pre-op, of course, but that's the MDT approach. And this was before we had the cultures back. And I said, start intravenous teicoplanin and meropenem immediately post-sampling. Actually, I must have seen him immediately pre-op, actually. And the meropenem is because he is from Nigeria, i.e. ESBL producer. So actually, that was quite good, actually, because I predicted what happened. And we started him on meropenem, 2 grams every 6 hours. There are no oral options. So this is the problem with antibiotic resistance, no oral options. He got standard 6 weeks of that, but very quickly after stopping, he started to leak. Another procedure was done, sort of fairly radical debridement, I think, with removal of the spacer, further sampling, back dressing. At that stage, there was rudimentary MDT, I think. And the patient, instead of putting another spacer in, the patient was actually kept on bed rest and traction to keep everything in place, which typically we don't do now, obviously. When we can get away with it. And again, the same organism was isolated. So this time, after next radical, after the further debridements, etc., and blah, 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 we restarted meropenem because we didn't have that many options, but we added in some amikacin this time with very close therapeutic drug monitoring. You had baseline audiology, which we do for long courses of aminoglycoside. You actually had 2 semi-elective further debridements because of the resistance aspect of things. He had no further positive microbiology. But in week 6, he complained of buzzing and hearing loss left ear, and that was the audiogram, which was different from baseline. So because of the antibiotic therapy, because of resistance, he lost his hearing in the left ear. Not entirely, but certainly partial loss. So I think it's very hard to argue, regardless of the management of the case, which you can debate about. And it's easy, this was quite a while ago, so it's a good case because we do things differently now when we've all learned and blah, blah, blah. But putting that aside, I don't think there's any doubt that the organism had an impact here, and hopefully it's fairly obvious. It caused, because it was resistant, prolonged use of broad-spectrum IV agents. There were no oral options, so we couldn't switch to oral. More operations, more complex operations than usual, prolonged hospital stay, therapeutic drug monitoring required, and even with that, he still lost or partially lost his left ear hearing. So I think we've already mentioned it today, and I don't want to over egg the pudding, but I think we all know that diagnosing bone and joint infections is quite tricky at times, and it's about synthesizing a lot of evidence sometimes. Sometimes very obvious, you open a joint, pus pours out, it's infection, it's easy. But actually often it's more tricky. And of course, we've already heard this morning, I don't need to go back through it, that the microbiology is pivotal, the part of the diagnostic criteria. So getting the organism, doing the correct things to get the organism, getting the right samples is absolutely critical. We know about the Oxford criteria. We're all very familiar with them now. We use them obviously in arthroplasty infections, but we also effectively use them in fracture-related infections as well. And they're built into the guidelines. So there's no doubt that making a microbiological diagnosis is key and important. And it's also important from, and we talked about this thing about, the organisms and whether really actually what we were touching on there is, should we always go broad because we're concerned about that we're missing bugs, as in the case you saw. And the problem with that, though, is that will generate antimicrobial resistance, and it will generate problems like C. diff, and it will also destroy the patient's microbiome, and that is not a benign intervention, and there are consequences of that. That's a whole talk in its own right, but I won't go into it in detail. So we have to balance this giving everyone very, very broad spectrum therapy versus narrow spectrum therapy. The other thing is narrow spectrum, contrary to popular belief, if the organism is susceptible to meropenem and benzyl penicillin will be the most potent antibiotic. Okay, so people often think it's the broader spectrum, big gun meropenem, but if the organism is susceptible to both, you should go as narrow as possible, because almost always, not entirely always, but very, very often, the MIC of that organism to that antibiotic will be lower with the narrower spectrum agents. So there's a complete myth about efficacy and broadness of spectrum, okay? When you move to a broad spectrum agent, it's because you want to cover resistance usually, not because they're more potent. And that's really important. So getting the organisms, pinning down the organisms, hopefully we might be able to do this better in the future for the reasons you've seen already this morning, is really important, because you really want to get the patient on the narrowest spectrum agent possible. I would argue that's true of local antibiotics as well as systemic antibiotics, but certainly true of systemic antibiotics. And choosing an antibiotic regimen, there's a lot of, it's not just, you don't just rely on one piece of information. You really need to acquire quite a lot of information about the patient and synthesize it. So clearly the organisms you grow and the susceptibility pattern and the nature of those organisms. We've talked about the lower grade pathogens like Koenig staph this morning versus the higher grade pathogens like E. coli. It's actually a lot easier to get E. coli out of a joint, metal joint, than it is to get Koenig staphs out of a joint. Sometimes the nature of the organism is important, and we've heard how the history affects that, and the whole 3, 4, 6 week arbitrary cutoff that we sometimes apply, blah, blah, blah. Clearly the complexity of infection, et cetera, is going to be important. Sometimes the nature of surgical intervention, whether you leave the metal in or not, does influence antibiotics. I think really importantly, that's why it's in red, allergies, intolerances, kidneys, liver, drug interactions. We are very poor at doing that as doctors. So we should do that, and you will eventually get in trouble if you don't do it. Adherence, I'm quite a fan of adherence. There's very strong evidence about adherence, not specifically with antibiotics infection, but with hypertension. Loads and loads of studies show that when you go from once or twice daily regimens to 3 or 4 times a day regimens, you go from high adherence to pretty low adherence, actually. So I always aim for once or twice daily oral regimens. Preferably using high bioavailability antibiotics, but there is a little caveat to that I'll come back to. Sometimes your local epidemiology or the nature of the patient, such as a soldier coming back from the Middle East or something like that, may make a difference. And we've already heard this morning, I don't need to really emphasize this, that despite all that, despite doing everything right, sometimes bacteria are evasive and they persist through a whole variety of mechanisms. Sometimes they are actually susceptible to the antibiotic, but they metabolically change, so they become pseudo-resistant in the small colony variant form that you may have heard of, for example, and that makes them much more difficult to treat anyway, regardless of whether there's biofilm or anything else, et cetera, et cetera. And of course, we've already heard about the importance of biofilm this morning, and if you're on the left-hand side, then maybe you'll get away with, if you like, lesser surgery with antibiotics. But if you're on the right-hand side with an established biofilm, then antibiotics are never, ever, ever going to cure that situation, ever, and you have to do surgery. And really importantly, the emerging evidence of this is biofilms probably form a lot earlier than we once thought, and also in chronic osteomyelitis, chronicity probably happens, certainly in some patients, a lot earlier than we once thought. So this whole concept of doing the right thing, getting it right first time, I know, but doing the right thing early, I think, is really important. Now, organisms associated with persistent infection, I actually don't, when you look at the literature, the evidence is weak on this, actually, really weak. I think the top line, and we've already heard about some more situations of concern, some of which are on the slide, some of which are not. I'll mention one or two off the top of my head as well. So I think the one thing, though, is never try, well, if you're going to do it, you're doing it pragmatically, but because it's not the gold standard approach. There's no point in trying to if you're going for a curative approach, there's no point trying to whether it's fracture-related infection or arthroplasty infection, don't low-grade pathogens, because it's pointless. It's not going to work and they're going to fail, almost certainly. If you're going to do it, it's pragmatic for some reason because of the nature of the patient or whatever, but don't do it, basically. It doesn't work. Those patients need revision. Fungi, I agree, generally bad, but fortunately not very common. Does it mean you absolutely should do a sort of revision for fungal infection? No, I don't think it does, actually. I don't think the evidence is strong enough for that. Does it mean you have to be highly alert to the fact you may need to do a revision? Absolutely, absolutely. Proteus is something I've learned over the years. Proteus is a horrible organism to get in an arthroplasty. When you grow it in the laboratory, it swarms on the plate. I don't know if it actually does that on arthroplasty, but actually there's fairly clear evidence from the literature, and it's my anecdotal experience as well, that Proteus is bad. So I don't like Proteus. Pseudomonas, archetypal biofilm-forming organism, generally bad, although I don't think it's as bad as Proteus, actually. That's my own gut feeling over the years, having treated a lot of both. I agree, polymicrobial is always something to be aware of. Sometimes there used to be a sort of thing about culture-negative septic arthritis, and be very cautious about, when I say culture negative sort of infected metalwork, and that there was some concern that that was associated with poor outcomes. Actually, there are at least 2 quite large observational studies recently that suggest that's not the case. But I think polymicrobial fungi, Proteus, Pseudomonas definitely are situations to be primed for revision metalwork removal. There's 2 large observational studies recently that have suggested, they use 30 days cutoff, it's arbitrary, but suggests that patients that have a DIR in prosthetic joint infection after 30 days, there's much higher recrudescence rate. So again, it comes back to that doing the right thing early. Personally, my experience is once you get to 4, 5, 6 weeks, that patient's high risk to fail in general, whatever you do. What is the robust evidence? There isn't much robust evidence, but I think this is reasonably robust. New England Journal of Medicine, antibiotic therapy for prosthetic joint infections, 6 or 12 weeks. And what they found is that 6 weeks was not non-inferior to 12 weeks, i.e. you should use a minimum of 12 weeks, at least based on this evidence. And it's really important to interpret this study correctly, because when you look at it closely, this is entirely driven by the debridement and implant retention group. So it's actually, I think, quite an important study because it tells us that, at least for the time being, and we'll wait for Solario and other studies, but at least for the time being, we should be giving at least 12 weeks post-DIR. And I would apply that to fracture-related infections as well when you've done a more debridement type approach as opposed to removing the metal. You should be giving longer rather than shorter. There are some systematic reviews. This is not the only one, actually, but I think it sums up the 2 key messages. In children, you can definitely get away with shorter, and that's because of the nature of their bones, particularly for hematogenic osteomyelitis, and I think we probably all know that, but whether we do it is another thing, but we probably know it. And actually, this systematic review showed more failures with short course therapy, and that was less than 6 weeks versus 6 weeks or more in this study, in the systematic review, in adults in spinal osteomyelitis and Staph aureus infections in general. I think someone else had that on the slide, Staph aureus. So maybe beware that situation. Now, people are very upset. Some eminent experts in the world are very obsessed with rifampicin. I'm not. It's a difficult antibiotic to use. It interacts with almost all with one exception, and even then it interacts a little bit. It interacts with almost all anticoagulant agents you will give to the patient, or could give to the patient. There is some evidence. This is a small trial looking at the combination of ciprofloxacin, which we discussed on one of the tables about the warning with MRHA and ciprofloxacin at the moment, fluoroquinolones. That's another discussion. But ciprofloxacin with rifampicin, which is a very classical bone and joint combination regimen, and suggesting some better outcome. But there's been a recent systematic review where even the author, I mean, if at best, very marginal benefit of rifampicin-based regimens, which should always use in combination, by the way, if you are using it. Very marginal benefit of rifampicin-based regimens, and the authors were very critical of the underlying evidence, and all the studies were small. So I'm not a great fan of rifampicin because it makes life a lot more difficult in clinical practice. And I've had a lot of good results over the years. You're always going to get failures in this field, but I've had a lot of good results over the years using monotherapy at high doses with highly oral bioavailable agents. So I don't think you need to be over clever, and actually I've become less clever as I've got more experienced and saw more patients. One little caveat though, so most once or twice daily highly bioavailable oral regimens are non-beta-lactams like cotrimoxazole, doxycycline, fluoroquinolones, for example. But there's emerging evidence, and it's not just in the UK, around the world, that actually penicillin allergy patients, when they're treated for infections in general, not orthopedic infections, but infections in general, they have worse outcomes, both for the infection and for adverse effects, including things like MRSA and C. diff, if they're treated with non-beta-lactam agents. So there's this drive now about delabeling penicillin allergy and getting patients on beta-lactams when it's appropriate to do so. And it doesn't, how we square that circle in orthopedics, I think, is yet to be determined. Having said that, and the reason we don't use too many oral beta-lactams in orthopedic surgery is, one is they tend to be 3 or 4 times daily, that's one, and two is they have poor oral bioavailability. But there are some exceptions. So amoxicillin actually has relatively good oral bioavailability, about 70–80%, depending on the study you read. You have to use it in decent doses. Cefridin, cefalexin actually have very good oral bioavailability and do get into the joint, as long as you do dose high. So 1 or 2 exceptions. But how we square this circle is, as we go forward, is sort of going to be interesting. But certainly, putting aside the oral, in terms of intravenous therapy, I think it is really important to try and delabel patients. And there is the PENFAS score. Won't go through it for sake of time, but the PENFAS score is very useful. It's online. Just Google it, and it'll tell you when it's safe to give a beta-lactam agent or penicillin in your patients. And that's clearly important when you're prescribing things like flucloxacillin. And that's the final slide, I think it is, before the summary. Oops, yeah, final slide. So obviously I've not talked about local antibiotics, which I think are already important. We're already using, we use them a lot. Some centers use them in a much more sophisticated way than we use them. Sheffield, for example. The evidence is weak, actually, for local antibiotics. There's some nice, fairly large observational studies which are suggestive, but observational studies are always fundamentally flawed. So it'll be really interesting to see what the Solario trial shows, and that could be a fundamental change in practice, a bit like the fundamental change after Aviva, or that should have occurred after Aviva. Although, interestingly, I still find patients on long courses of intravenous antibiotics when they're doing well, particularly when they go away on holiday. Okay, so summary, I think the bugs matter in a whole myriad of ways. I haven't talked about all the ways the bugs matter. Don't low-grade pathogens. It's just, unless you've got a really good argument for doing it. But don't do it because you'll fail, basically. It's failure, 100%. Beware of some organisms. I don't know if they should absolutely 100% drive what you do. I think you just need to be cautious. So Proteus, Pseudomonas, fungi, polymicrobial, I agree, possibly Staph aureus, but Staph aureus, of course, is the one we deal with all the time. Antibiotic choice, again, depends on a myriad of factors. It's really a more detailed talk in many ways, but it should really be mostly oral, high bioavailable agents, once or twice daily regimens. But there is that sort of slightly awkward circle to square with the emerging beta-lactam sort of allergy or penicillin allergy evidence. Route and duration is driven by response and complexity almost always. But in general, when the patient's doing well, you don't need to give them weeks of intravenous antibiotics. If the patient's doing well, they're usually off intravenous antibiotics by day 7 at latest. And if they're doing really well, they can switch earlier. Role of rifampicin, yeah, so I was involved in the REST trial, which was rifampicin in Staph aureus bacteremia in combination with flucloxacillin. And the systematic review and all the sort of fundamental evidence and everything pointed towards rifampicin being really good in that, in rifampicin bloodstream infections. What we found when we did a 1,000-patient trial is that it caused more harm than good. So I'm not a great fan of rifampicin, and I would encourage you not to be, make your own minds up, because don't take my word for it, but I wouldn't be indoctrinated by some of the, European advocates, let's put it that way. Okay, thanks very much for your attention.